Satish Raj. I'm pinch hitting for our fearless leader, Dr. Murillo, who's back in the homeland, I'm told. We're lucky today to have Michael Chiu present Grand Rounds for us. Many of us on this call will know Michael. He did his cardiology training here a few years back and was an excellent trainee, and clear potential was seen there. Mike has actually been around Calgary longer, but hiding in the intensive care unit for a couple of years. After his cardiology training, he pursued a critical care fellowship and decided that wasn't far enough away, and so went all the way to Vancouver for an echo fellowship, where he is, which he's currently completing. We are looking to recruit Mike back, and as part of that process, he's agreed to give Grand Rounds to share some thoughts and his visions and his interests that have evolved and developed over the last few years. He's going to talk today about the potential for cardiac research in the intensive care unit. I'm sure we're all looking forward to an opportunity to hear Mike's thoughts on this and hopefully probe him with difficult to answer questions that will puzzle him at the end. So keep those in mind. With that, Mike, the floor is yours.
Perfect. Thanks very much, Dr. Raj. As Dr. Raj stated, I'm going to be presenting a little bit about some of the research that I've been doing between the two departments of cardiac science and the intensive care unit. So first of all, I don't have anything to disclose, no relationships with financial interests or connections with pharmacy at this point. So the last time I did Grand Rounds was quite a bit less serious. So this will be quite a bit of a switch. And that was probably, almost three and a half years ago. So a little bit of a background about myself. So went through Calgary for the majority of my training, both in terms of my medical degree, internal medicine, cardiology, intensive care, and now at the University of British Columbia for echocardiography with the Vancouver General Hospital Group. So what are my interests? So the reason I pursued both cardiology and critical care is I have clinical and research interests that are primarily within the field of cardiogenic shock, cardiovascular intensive care, and cardiac pathology in the intensive care unit. So I thought with this Grand Rounds, given that, there's been quite a bit of work that and projects that we've been completing over the course of the last few years, I'd share some preliminary results and kind of promote a collaborative cardiac and ICU research initiative. So the projects that I'm going to be presenting is one on cardiogenic shock, the role of heart rate modulation, then a kind of a bench to bedside project combining both fields of heat shock proteins for cardiovascular disease as well as for acute respiratory distress syndrome. And I'll touch on, the role of potential of stereotactic radioablation of cardiac arrhythmia in sick patients, as well as subarachnoid hemorrhages and stress cardiomyopathies. And that's only if we get to it with time. So first, the project that kind of got me interested in the field of collaboration is I was very interested in cardiogenic shock during my cardiology training. And with the group of Dr. Howlett and Dr. Sharma, we worked on a project to see if there was a role of heart rate limitation. So just kind of from the background of cardiogenic shock, this is a syndrome that is characterized by severe impairment of the myocardial performance. With pump failure, there's diminished cardiac output, filling pressures become elevated, and the end organs suffer with hypoperfusion and hypoxia. So there's various criteria and some large trials that have been done in terms of, diagnostic criteria, but typically, it's a low blood pressure, systolics less than 90 for over 30 minutes on requiring vasoactive medications with the patient being volume resuscitated. And there's evidence that, the body's still not getting enough cardiac output. That would include from urine output, cold extremities, and such. So common causes, most common is still acute coronary syndromes, but there's other complications including stress cardiomyopathy, just decompensated heart failure, myocarditis, and valve disease. And some of these pathologies, don't exclusively live in the cardiac intensive care unit, as some of these can present to intensive care units, such as with stress cardiomyopathy and a neurological disease, or myocarditis with, confounding other kind of multi-system injuries. So the physiology of cardiogenic shock. So it's quite a vicious cycle. So typically thinking about it from the left ventricular dysfunction standpoint, there's a reduction in cardiac output and stroke volume. That reduces peripheral perfusion. It results in the body trying to maintain perfusion by further vasoconstricting, which kind of further leads to a syndrome of worsening ischemia. All of this lack of blood flow and results in an inflammatory state. And that results in just a worsening cycle of cardiogenic shock where the body is pumping out, having a harder time delivering blood flow, and the vascular resistance continues to increase. So patients typically present based on, the Forrester classification. There's the, cold and wet classic cardiogenic shock, where the filling pressures are all very high and the vascular resistance is very high. There's euvolemic cardiogenic shock, where patients, have an improved volume status, but still suffer from a low output state. And then there's warm cardiogenic shock, which is a mixed shock, which can be seen in patients with both underlying, cardiac dysfunction, as well as probably another process such as sepsis or a distributive shock process. But in all cases, they all have a reduction in their cardiac output or cardiac index. So the determinants of cardiac output is, heart rate by stroke volume, and stroke volume is mediated by things such as preload, contractility, and afterload, and heart rate is based basically on sympathetic and parasympathetic drive. So, in terms of when the stroke volume goes down, the heart rate typically goes up in order to try and compensate and maintain cardiac output. Our current therapies, or the majority of our therapies, focus on treatments for stroke volume with, preload to help offload the ventricle with nitrates and diuretics, improvements in contractility with inotropes or, afterload reducing agents to help reduce the amount of pressure the pump has to pump against. Some of these therapies also indirectly affect heart rate, such as with inotropes, where you can increase the heart rate, and that can all help to improve your cardiac output. However, the role of heart rate in cardiogenic shock is less well studied. So if the patient has a slow heart rate, it's typically thought that, to improve cardiogenic shock, you could increase that rate. That would involve using vasoactive medications with chronotropy, as well as even using a pacemaker to try and help augment rate to improve cardiac output. However, the other standpoint is what to do in tachycardia. So tachycardia is thought to be compensation related. It's classically, you don't want to decrease heart rate because it's thought that it can worsen the cardiac output state. There's a force frequency relationship between heart rate and cardiac contractility, and this is primarily in a healthy heart. It's called the Bowditch-Treppe effect. So it's a force frequency relationship. So inotropy, or how hard the pumps, can be related to circulating catecholamines, how much sympathetic activation there is. But also there's a relationship where if the heart is pumping faster, is seen kind of the figure down in the right here. If the action potential is higher, the heart is firing faster, that you have an increase in actual contractility. And this is thought to be secondary to, rapid stimulation resulting in more sodium and calcium making its way into the myocardial cell. However, in a failing heart, or in a heart that is in distress, this Bowditch-Treppe force contraction phenomenon actually is not seen, and it actually could be the opposite. So with a failing heart, or a heart that's under stress with increased rate, there is increased myocardial oxygen consumption as well as requirements. This can worsen underlying cardiac ischemia, especially in patients that have multivessel coronary disease. and it can overall reduce contractility. This also impairs diastolic filling time, so multiple things that can affect the amount of cardiac output. So is there a means to limit tachycardia? So, if the patient's heart rate is going quite quickly with cardiogenic shock, and we feel that it may not be beneficial to their output state, what do we have? So typical medications to limit tachycardia are beta blocker and calcium channel blockers. However, they all have a negative inotropic effect. And this figure just on the right here just demonstrates in a patient with a normal heart that as the patient heart rate increases, the force of contraction increases. Whereas in a patient with heart failure and significant heart failure, the opposite is seen, where with increasing heart rate, the force of contraction actually decreases. So that brought me to thinking about ivabradine and the group to think about ivabradine for the role in terms of heart rate limitation. So ivabradine is indicated in chronic heart failure patients, either who are intolerant of beta blocker or on maximum beta blocker therapy, more so in terms of improvement for symptoms or in decrease in hospital admissions. But there has no, for this heart, it's not been used in cardiogenic shock. This medication was looking to be quite a potential for patients that have very high heart rates, as there's no decrease of inotropy with this medication, and side effects are actually quite limited, with just visual phosphenes. So the mechanism of action of ivabradine, as we mentioned on the previous slide, not having effects on inotropy, is it slows the heart rate mainly by slowing the diastolic depolarization of the sinus node action potential. So just basically seeing down below is that they just slow the diastolic depolarization and just lowers the heart rate in terms of the next beat that it would fire. So it brought us to our research question of, is there a role of heart rate limitation in cardiogenic shock? So wanted to see if we could evaluate the safety of giving ivabradine in this patient population, and what does the hemodynamics look like when we do slow the heart? So from 2017 to 2019, while I was doing my cardiology fellowship or training at the Foothills Medical Center Cardiac Intensive Care Unit, we found patients with newly identified cardiogenic shock. They all had a PA catheter placed, an echocardiogram, and they looked for patients with a cardiac index around 2, less than 2.5, elevated filling pressures, and typically tachycardic. From there, we included patients that had a new diagnosis. They they did not have confounding issues. They had no contraindications to they didn't have contraindications to either ivabradine or beta blockade. So going through this, we started to give these patients ivabradine. So starting dose of the lowest at 2.5 BID, and then further titrating it up at a Q12 kind of dosing until either we achieved a good heart rate that was, under 90 to 100 to a maximum dose of 7.5 milligrams twice daily. Then we followed the hemodynamics. So we looked at using the PA catheter, looked at invasive hemodynamics every 12 hours, as well as typical organ perfusion markers such as creatinine, lactate, looking at volume status with sodiums, as well as looking at the hemoglobin. And we also allowed these patients just to be on standard medical heart failure therapy, so including inotropes, diuretics, afterload reductions, at the discretion of the attending team taking care of the patient. So the primary outcome was to look for, improvement in hemodynamics over 72 hours, and then look for bad adverse outcomes. So, further need of vasoactive medications, bradycardia, worsening hemodynamics by PA numbers, or, the occurrence of arrhythmia. So we published this, I believe, in around 2020. It was in the European Heart Failure Journal, talking about initiation of ivabradine in cardiogenic shock. So we had 5 patients in a kind of a smaller study, and all these patients were, in the new presentation to the cardiac intensive care unit. 4 of them were on milrinone, 1 of them was on dobutamine. They were all on kind of a baseline of cardiac medications. Some had some small doses of beta blocker already been titrated for this population. And these were their hemodynamics. So I'll go through kind of a summary slide after, but just to kind of show the general trends of what we were looking at. We had the general hemodynamics. We looked at the 6 hours, 12 hours, 24 hours, and 48 hours. And what we saw was, I'll just highlight two trends. So one was the heart rate. So obviously our goal was trying to decrease the heart rate. Then we also followed the central venous O2 or the mixed venous O2. And we looked at the stroke volume and the left ventricular stroke work index. In both cases, around the 48-hour mark, we had quite an improvement in heart rate. So these patients, came in with a heart rate that averaged somewhere around 106 up to 110. And then by the end, we're around somewhere around 88 up to about 91. And this was with the titration of ivabradine. We saw association of improvement in cardiac output and cardiac output seen by the central venous O2 kind of improving into the mid 60s, and our stroke volume increasing as well. Also to note, just not highlighted, the creatinine and the lactate at markers of perfusion also went in a similar trend. So rather than looking at the big table, I thought just from a summary slide of this study, we just did more of a pilot study to see what would happen when we would provide this medication for these patients. So we used 5 patients. 4 were non-ischemic cardiomyopathies and 1 was an ischemic. 3 were basically a brand new diagnosis of heart failure, and 2 of them had some grumbling heart failure in the community. And all patients had moderate to severe LV dysfunction with an average cardiac index of about 1.7 liters per minute and a central gas of about 51%. So from there, we noticed the average heart rate on presentation was about 106 with a mean arterial pressure of 73 on standard therapy. At 48 hours after initiating ivabradine, and the majority of the patients were able to get close to the 7.5 milligrams BID, with the average dose of being about 5 milligrams. We found that there was at 48 hours, there was a reduction in the heart rate. So it went down to about 88, and there was an improvement in filling pressures of the heart. This was associated as well with an increase in, mixed venous oxygen saturations, stroke volume, and right and left stroke work index. So that was what we found in our small non-randomized series of patients, kind of just as a pilot study to, identify, does this have potential in terms of improving patients with cardiogenic shock? So it led us to think about the next step. And I'm hoping that in the future, we can start this project back up in terms of looking at, comparing it to placebo or standard therapy. So in this one, I think that it'd be nice to have a control group of where we have patients with, presenting both with cardiogenic shock and randomizing them to either have control therapy, which would be placebo pills mimicking ivabradine versus the typical titration of ivabradine, and following very similar kind of markers, such as, what does the PA hemodynamics look like? Do these patients have an improvement in their abilities to wean off vasoactive medications and such? So that's the next step of where we're hoping to take this project. We'll be looking at very similar things, which is, stroke volume index, cardiac output, and secondary outcomes of safety. So the implications of this study is, cardiogenic shock is a very common problem in the ICU and CICU. Many of these patients, are quite unwell, and we want to see if there might be a benefit in terms of heart rate limitation in patients with cardiogenic shock, both in the ICU and the CICU. This can also be used as an adjunctive to inotrope therapy, as some people have quite a bit of tachycardia being on dobutamine or milrinone. And furthermore, I think it further provides us an understanding of cardiogenic shock. So I thought I'd switch gears and present another research project that I've been working on over the course of, probably the last 7 or 8 years or so. It's in regards to heat shock protein. So this is more of kind of a bench to bedside kind of approach of, combining cardiac pathology and acute respiratory distress syndrome. So the first part is to, chat a little bit about heat shock proteins. So these are proteins that are expressed during stress, and they whenever a body's under stress from infection or inflammation, these proteins are expressed, and their traditional roles are kind of for protein folding and assisting with protein conformation. Both basically with a way of helping to preserve bodily functions in times of stress of the any kind of stress of the body. It took us to look at a protein called heat shock protein 27, and this was with Dr. Ed O'Brien's lab. And from there, it was noted that this small heat shock protein was transiently upregulated in stressful stimuli, specifically kind of in cardiovascular disease. It's basic known role prior to being investigated in the role of cardiology was, just to recognize and bind misfolded proteins. And it may have had an element to do with Parkinson or Alzheimer's in terms of the brain. But strictly from the thoughts of cardiovascular disease, in 2013, Dr. O'Brien's group published about the levels of this heat shock protein in patients with coronary artery disease. So in a group of patients that, had atherosclerosis, and carotid stenosis, the heat shock protein levels that are shown here on the top figure were found to be significantly lower than in control groups that were deemed to be healthy. These patients were followed up to almost about 2,000, days to try and see if there was an effect in terms of their, event-free survival. So recurrent, major adverse cardiac events or any kind of pathologies related to heart disease or cardiovascular disease. And it was noted that patients with this high heat shock protein levels actually, had a better event-free survival than patients that did not. And that's kind of shown in the panel below on the Kaplan-Meier survival curve. So it was found that maybe this protein could be used as a predictive means of, predicting 5-year risk of, cardiovascular events. But we wanted to see, could it be potentially protective? So mice that were prone to atherosclerosis, the ApoE mice, were bred to have overexpression of this heat shock protein 27. And that was what was seen in this panel here. We got these mice and they were bred up to have a lot of heat shock protein levels, and it was significantly higher than the donor mice that were just, the ones prone to atherosclerosis. So following these mice out, it was noted that there was actually a significant difference in the amount of atherosclerosis that was noted. So in these mice that were prone to developing atherosclerosis, having them overexpress this heat shock protein actually significantly decreased the amount of cholesterol plaques that were seen in the mouse aorta. That's just seen in the figures shown below, where the red spots on the stains all represent cholesterol plaques, and the top panel is the control without the overexpression of heat shock protein. And below we can see that, that there are less of these cholesterol plaques. And that's outlined in the bar graph shown below, that we found almost a 50% reduction in these aortic plaques. So the next thought was, if we can overexpress it in the mice and it's be protective in terms of forming atherosclerotic disease, how about the exogenous administration and using it as a therapeutic target for atherosclerotic disease? So from there, these the same mice, these ApoE mice, were given heat shock protein 27. And what was found was a very similar pattern. So again, harvesting the mouse aorta, you can see that the amount of plaque in the ones that were given HSP27 had a reduction in the amount of cholesterol plaque, and it was about 31%. So it led us to think that this possibly could be a therapeutic target to say, by augmenting heat shock protein 27, we can reduce the amount of atherosclerosis or the progression or development of atherosclerotic disease. And that's what this is just another slide showing some of the pathology figures in terms of the lesions showing less cholesterol and plaque. But additionally, what was noted, when looking through the serum and the blood of these mice, and in terms of human populations with cardiovascular disease, not just this heat shock protein levels were different, but there was also some autoantibody that attaches itself to the heat shock protein level that was also lower. So we became interested to know, well, there's this autoantibody that also interacts with the heat shock protein, and how do they interact together? And maybe it's their ratio together that affects how patients with cardiovascular disease perform. And this is seen in these two bar graphs. So, in patients that are in the control, they have higher level of heat shock protein 27. Patients with cardiovascular disease had this lower level of heat shock protein 27. But again, they had this lower level of an autoantibody that binds to the protein. So we thought that maybe if we can help augment the amount of autoantibody, then maybe that could be a vaccination strategy for heart disease. So this brought us to the thinking that, when there's a cell stress, there's two parts of it. There's the protein as well as the autoantibody to them. And the combination of having the heat shock protein bound to its own antibody may be beneficial in terms of, its effect on how it modulates atherosclerotic disease or cardiovascular disease. And so there I started looking at, how does this protein and autoantibody work together? And is this a role for targeted therapy? So going back to doing some, protein structure and protein analysis, we looked at the protein to see what does it look like. So I did some homology modeling and some modeling of the protein and found that, it's a pretty straightforward protein and has three main sites. One's this big area that's, is filled with a structure called a beta sheet that forms a domain that we believe many things bind to. Then it has two additional components. We think that these two heat shock proteins bind together to form a dimer, and the dimer forms together to form a group of a hexamer. So that's what all the bioinformatics modeling thought that this, heat shock protein pathway would look like. So the next part was to say, where on this protein does the autoantibody interact? So looking at it again, the best way to do it was to break it up to see where would the autoantibody bind to. So we took the protein and we synthesized 4 recombinant protein segments of, one having different parts of the protein to see which was the actual one that, provided this benefit from atherosclerosis. So the ones that we were most curious in is this huge area here, which is this binding domain that had all of these beta sheets. And we kind of looked, we're interested in the central segment as well as the C-terminal segment that we thought was the, responsible for maybe these beneficial cardiovascular targets. And we wanted to make sure that this part of the protein was actually responsible for it. So we wanted to see if it had its intrinsic chaperone activity. And we found that those two segments, one having this big binding domain, as well as the C-terminal tail, were the two that would retain the ability to protect the proteins. So we thought that this segment of the protein was responsible for the job of potentially even being a therapeutic target for atherosclerotic disease. So we looked at the structure of how this changed, and looking at the doing different techniques such as circular dichroism, dynamic light scattery, a little bit of NMR. We found that the protein binds to the central segments, and it's seen by an increase in the beta sheet structure, so those long strands. Then following from that, we know that by looking at the size of these proteins, that they were increasing as they came together, for further kind of confirming the modeling that was done by bioinformatics, that it forms this large, 6 heat shock protein dimerized structure. And then from there, we kind of proved that about one of these proteins binds to 2 autoantibodies. So looking at all of those, it became, what's the pathophysiology? We understand now how the protein and the autoantibody work together. But the next step is to figuring out, how does it actually attenuate inflammation and atherosclerotic disease? So from there, we started to look at, what does it bind to? So we found that this complex that we identified, this heat shock protein 27 autoantibody complex, binds to the cell surface, and it binds to something called toll receptor 4. So that's just what's shown in these figures here, that the heat shock protein, in addition to the heat shock protein with the autoantibody, caused a whole bunch more cell surface binding. And where it was binding to was this receptor called TLR4. And that's just highlighted in these figures over here. So TLR4 is very important because it leads to many parts of the inflammatory cascade, such as NF-kappa beta with inflammatory cytokines and the innate immune system. And we felt that its anti-inflammatory and anti-atherosclerotic properties may be associated with this. So we started to look at the signaling, and we found that when the protein, which is here, was administered with the autoantibody, we had quite a significant increase in terms of the NF-kappa B signaling. And that's in comparison to something that would be, a typical activator, such as lipopolysaccharide. So what does this HSP27 autoantibody do when it binds the pathway? So it really just inhibits the NF-kappa B activation, and how it does that is by competitively binding to this TLR4 pathway. So that's what we found with these bar graphs here, is that with the administration of the autoantibody, which is shown here on this panel, with the heat shock protein, we have much lower amounts of this NF-kappa B inflammatory cascade signaling that occurs compared to a control, which would be something like lipopolysaccharide. And that's just shown here in the next panel on the right, where we have a significant decrease in the amount of inflammation that would happen, about 77% in this study. So looking at the inflammatory markers, we found that things that would help in terms of reducing inflammation, such as increased IL-10, increased up by about 167%. So we felt that maybe that this autoantibody complex was helping to promote the anti-inflammatory cascade off of the body's innate immune system, and that's how it would work. So that brought us to the thought about atheroprotection. So we're like, why don't we know that we're kind of decreasing inflammation? Why don't we try and administer this recombinant protein and recombinant autoantibody as a vaccination strategy and follow what it does to the cholesterol level? And that's what's shown in this panel here, that with the protein given, in addition to the autoantibody, there's a significant reduction in the amount of cholesterol that is being uptaken. And this was from liver panels with the LDL uptake. This was thought to prevent foam cell formation, which is known in the pathway of creating atherosclerotic disease. So we found about a 38% reduction. So this brought us to our vaccination strategy. So using the same mice, the thought was, how about trying to vaccinate these mice with the recombinant protein as well as the autoantibody, and then following what happens. So, the mice were given injections of to create these autoantibodies to heat shock protein 27. And that's just what's shown in this panel here. By about 1 week, they had started to have an increase in the levels of the autoantibody to heat shock protein 27. And this was actually quite encouraging, because with the administration of the autoantibody and creating a vaccination strategy, there was actually quite a bit of a reduction in the amount of cholesterol that's seen. And that's just shown in the panel here on the left, both from a male and a female mice, that there was actually a reduction in the cholesterol size, and when these mice made it out to about 8 weeks. So that was seen from the ability to kind of reduce the amount of that this vaccination strategy was successful in terms of reducing plaque formation and atherosclerotic disease. And the pathophysiology currently is being worked on, but it's felt to be secondary to, decreased LDL receptor uptake, as well as from a decrease in plasma PCSK9 levels. But I know that was a lot of basic science, but looking through further, the thoughts of how it works is really we think our heat shock protein autoantibody complex binds to TLR4. And from there, it modulates this pathway called NF-kappa beta that really helps to reduce the amount of inflammation that the body sees. And from there, it also reduces cholesterol uptake. And it's thought to be its pathway of how it's beneficial in atherosclerotic disease. So, working in the ICU during COVID, I became quite interested to see, how does this relate to patients with COVID pneumonia? So one of the pathways that it's thought that COVID actually can cause quite a bit of lung inflammation is through the NF-kappa beta response. This was kind of published in the early fields of COVID pneumonia, where patients were having blood tested to see which part of the immune cascade was being activated. So it was presumed that the virus and its RNA triggers were really just resulting in high amounts of inflammation, and thought that this pro-inflammation may be related to NF-kappa beta. Thinking of that, I thought, does heat shock protein levels also correlate, or can they be, could augmentation of either the autoantibody or heat shock protein 27 be useful in terms of management of COVID disease? So that's began when I started collaborating between the two groups, between ICU and cardiology. And from there, I worked with one of the intensivists who had an ongoing study of looking with patients with acute respiratory distress syndrome as well as thrombotic disease. So we felt that this would be a good population to test this theory out to see, what do the heat shock protein levels and their associated autoantibody levels look like in this population. So I found patients that had hypoxemic respiratory failure, typically with a PF less than about 300. They came to hospital within 24 hours of ICU for mechanical ventilation. They, didn't have any pre-existing disease that would affect their immune system, such as they weren't immunocompromised, they weren't on long-standing glucocorticoids, not on any immunomodulating disease. In this population, we collected their data and we wanted to see what their heat shock proteins looked like at 24 hours and 72 hours, as well as the autoantibody levels. So from there, we would look at our primary outcome of, what do these levels look like, and does it actually affect their morbidity, their duration of mechanical ventilation, the degree of their hypoxemia, the days in ICU, or their mortality. So it brought us to our patient cohorts. So we had a COVID cohort and a non-COVID cohort, because I wanted to see what the difference would be between the two. So there would be, basically they were quite well matched. The patients were about 59 and 52, about in their 50s, still predominantly male in terms of the population that presented. And then of course, from the treatment arm for COVID, many of them, the majority of them were getting dexamethasone and compared to the COVID patients. Looking at it further, the patients typically presented sicker in the non-COVID population. That was characterized by a score that we called the SOFA score, but the patients with COVID had a worsening hypoxemia with a lower PF ratio. So just to highlight what we found based on bars and shown in these bar graphs is patients that had were admitted to the ICU, the patients that were non-COVID are shown in black, and the ones that had COVID were shown in white. So heat shock protein levels on day 1 and day 3 were found that in the COVID patients, they all had higher levels of heat shock proteins compared to the non-COVID patients. And this persisted from kind of day 1 to day 3 in both populations. Next, we looked at their autoantibody level, and what we could see from the autoantibody level that there was not much difference between the two groups. It was mainly just the heat shock protein levels. So it became a wonder if the ratio between, as we know from our previous studies, that the autoantibody binds to the heat shock protein, and probably in a fashion of 2 to 1, that is an upset of the ratio between the autoantibody and the heat shock protein, um, of cause for why these patients may be in a sick or hypoxemic state. So this is just a bar graph to show the autoantibody to heat shock protein levels in the COVID and non-COVID patients. And what we can see is that they have a much lower amount of autoantibody to heat shock protein compared to the non-COVID patients. So this became interesting to say that maybe it's an imbalance between the two parts of the protein, the autoantibody and the heat shock protein, that is resulting in them having such bad hypoxemic respiratory failure. So this was just a table kind of outlining those findings. So the heat shock protein levels were a lot higher in the COVID patients, and the autoantibody ratio to the heat shock protein were quite a bit lower in those patients with COVID compared to the non-COVID. So that's just seen here with our average heat shock protein levels being 600 compared to 400, and our ratios being quite a bit lower in the COVID arm compared to the non-COVID arm. So we wanted to see, does this affect its outcomes? So, comparing COVID patients to non-COVID patients, COVID patients on the left, non-COVID on the right, we found that COVID patients, of course, had a longer duration of mechanical ventilation, longer length of stay in the ICU as well, but a very similar stay in hospital to non-COVID patients. So they may have had worsening respiratory failure, and that's consistent with what we've seen otherwise. And the mortality was also higher in the non-COVID patients, just typically because of their multi-system injuries. And COVID patients typically came in with usually just one system failure, which was the lungs. But that brought us to wonder a little bit about, what if we can use these levels of heat shock proteins or the autoantibody levels to understand the clinical outcomes, or maybe even think of possible, supplementation of this population who have COVID pneumonia. So I used this data and I stratified the COVID patients into either having high heat shock protein levels or low heat shock protein levels, and breaking them up between lower and higher levels of autoantibody to heat shock protein 27. So using a median cutoff that was kind of arbitrary based on the middle level of the groups, I created 2 groups within the data set. So these are the 2 groups. So, one group that was significantly higher of heat shock protein levels and one that was significantly lower. And this kind of persisted to day 1, day 3. And this also followed the autoantibody levels. So what did we find from that? So, the patients that had higher heat shock protein levels are shown in black. The ones that had lower heat shock proteins are shown in white. And we found that patients that, and this is, the autoantibody levels. I'll just move on to the next slide, actually. So what we found is patients with higher heat shock proteins and the lower autoantibody to heat shock protein ratio, they actually had quite a bit worsening hypoxemic respiratory failure. So the patients that, had these higher levels of the protein or a lower ratio between the autoantibody and the heat shock protein, is their PF ratio was quite a bit lower. So it was just under 150. Whereas patients with the lower heat shock protein levels or the higher ratio of autoantibody to the heat shock proteins, they actually had better respiratory function, as they were able to oxygenate a bit better with a PF ratio, that was significantly higher. Also, what was interesting to note was the comparison between day 1 and day 3. So the patients with this higher heat shock protein levels or this lower amount of autoantibodies, they actually persisted on to have worsening hypoxemic failure at 3 days, whereas you start to see a trend of improvement with the PF ratio increasing close to 100 in the patients with the lower cohorts. So that's what's just been shown in these figures here. So we wanted to see what the outcomes is of these heat shock protein levels. So again, patients with the higher heat shock protein levels at COVID actually required a longer duration of mechanical ventilation, which is shown in black. They had a longer length of stay in hospital, which is in white, and they had a overall longer stay in not just the ICU, but also in the hospital. This is compared with the COVID cohort that had lower heat shock protein levels. So we see that they had a lower amount of mechanical lower duration of mechanical ventilation, and didn't need to stay in hospital or the ICU as long. And this is kind of a comparison of mechanical ventilation. And basically what we saw that is most patients with lower heat shock protein levels, their days of mechanical ventilation were quite a bit less compared to patients with the higher heat shock protein level, which is shown in the black line comparatively to the hash line. So in terms of survival, it was also found that there was a separation in between the patients who had lower heat shock protein levels compared to the higher heat shock protein patients. So they not only had longer duration of mechanical ventilation, but it also put them at increased risk of mortality. So this made us think between the link between the two. So, now that we know that there's, links between COVID and cardiac disease in terms of myocarditis and, bradycardias, all of these put together makes us wonder, is some of this link related to the heat shock protein pathways? And some of the studies right now are looking at H2 and all the different immune modulators. But we wonder that, based on what we've been working on from heat shock proteins in atherosclerotic disease, if this also kind of focuses on the effects of cardiac dysfunction. So the implication of this study was to kind of look at to enhance our understanding of COVID. Furthermore, I hope to kind of look at this a little bit more with thrombotic risk, as acute coronary syndromes and all the such, there's an increased risk of thrombosis. As well in the COVID patients, they have an increased risk of pulmonary embolism. So I wonder if the inflammatory cascade from the heat shock protein levels are related to any of this. This can lead to further therapeutics that can both be helpful in the world of atherosclerotic disease, as well as with COVID hypoxemic failure. And it can also serve as a biomarker to say, if we can just test these levels, maybe we can predict which patients may benefit from, more advanced immune therapies, such as, the TNF inhibitors and all the new medications that we've been providing for patients with, failure in the intensive care unit. So this has started to be thought about actually, and we just found this paper that was published from a group in Cuba, and they were starting to use these immunomodulator peptides, which are these heat shock protein peptides, to see if that helps patients with COVID pneumonia. So a group in Cuba has started working on using a different heat shock protein to see if that could help in terms of, reducing the inflammatory cascade. This is just a figure from their paper that actually showed that, administration of this heat shock protein was beneficial in terms of reducing some of the inflammatory products such as IL-6, TNF-alpha, and IL-10. So where do we hope to go with this project? So currently it's just finishing up recruitment, and we want to correlate, our patients with respiratory failures to cardiovascular outcomes, and follow on a little bit more of the inflammatory pathway to see, what are the cytokine levels and how does this correlate with thromboembolic events. So I know I'm running short on time and there's a couple more projects to go through, but I think the best would maybe kind of just to open that up to questions from those two projects rather than rush through some of the other projects, which are mainly in regards to, using a means of stereotactic cardiac arrhythmia radioablation for patients on extracorporeal life support. And well as the last project I was going to chat about was in regards to subarachnoid hemorrhage and stress cardiomyopathy, which is currently a study that's ongoing in our intensive care unit, just to see if, which patients with what degree of subarachnoid hemorrhage, develop significant LV dysfunction. So rather than rush through some of those projects, I think I'll just go to the end here. where I'll open the floor up for questions to our conclusion and for questions. So overall, I think there's increasing complexity of patients in the cardiac intensive care unit, and they're being co-managed by ICU physicians as well as cardiologists. So there's a big group, there's a large opportunity for research between the two and bridging the two. And I would have thought about doing some of these projects, if I didn't get exposed to the patient population. So I think putting these together, it allows us to develop, advanced management options for cardiac patients, and is a good opportunity for collaboration between cardiology and ICU research. So just in the interest of time, I'll open it up to some questions now.
Thank you, Mike. Honestly, I was getting fatigued just listening to all the work that you've done in the space. Greg Schnell has thrown in a comment. I don't know if you see it, but just for the group. He liked your talk. He sort of reviewed different accomplishments, and he wanted to thank you for helping out over the last 9 days. But he, as much as he loves heat shock proteins, his greater love is for echo, and he was hoping that you could say a few words about some echo research that you might be interested in.
For sure, yeah, and that's kind of the role of grateful to be part of the Vancouver group. Learning level 3 echo and more advanced things from echo. I feel that especially in the role of cardiogenic shock and patients in this cardiovascular intensive care unit and CICU, there's a lot of need for advanced imaging to understand the pathology of the heart. So some of the things that from the echo imaging that I'm interested in is in these patients that present with cardiogenic shock requiring ECMO or requiring to be on with an invasive PA monitor. Those come with inherent risks. There's actually field in the research that I'm interested in terms of these small disposable kind of TEE probes that are actually attached or combined with an OG. So they form the same ability to kind of deliver food, deliver, all the things an OG would be. But at the end of it, there's actually a very low grade ultrasound probe. And you can be using this to actually follow VTIs of the heart with extracorporeal support. And that way, instead of having a PA catheter, which may be finicky and difficult, you can have actually a non-invasive means of actually measuring, cardiac output and seeing if these patients are weanable instead of proceeding on and doing a full TE. And it'd be something that could be left in, a patient for 72, 96 hours, allowing for a kind of a ultrasound or echo approach to weaning and managing these patients. Currently, most strategies are just to do either, if they have echo windows, do a surface echo or do a TEE, but having something continuous can kind of give real-time changes, very similar to a PA. So that's kind of the thing I'm interested in terms of the fields of echo and ultrasound. And of course, I'm hoping that the more development of echo-guided procedures, especially focused on TEE, from septal ablations to different valve clippings and all of those things that are nicely done, that I'll have a role in that and can help further that field in terms of research within our department.
So Catherine Kavanaugh had.
Hi, Mike. Nice to see you again. Fantastic talk. And I'm delighted to see how much you've accomplished in such a short period of time. Fantastic. My question is, I was wondering if you were able to tell us whether or not the vaccines have had any effect. Have you looked at vaccines with respect to the heat shock protein?
Yeah, so specifically, I think we're thinking about the COVID vaccine and the heat shock protein. So I actually have a few different groups of patients, and so it's nice that we have blood work from patients from the first, second, third wave, because we actually have different therapies. So the first wave actually has mostly non-vaccinated patients, maybe one dose of Pfizer, and then subsequently by the fourth wave, we have patients actually that have two vaccinations. So we're interested to see. I haven't actually gone through that data to see what the differences in between their inflammatory cascade, what the heat shock proteins look like between those two populations. But that's something that that we're looking at as well. The same thing is actually I'm interested in, the patients that we started giving, remdesivir or tocilizumab to see if those actually have an effect on the heat shock proteins as well, and maybe give guidance to, who would benefit from different kinds of, all the new medications rheumatology uses in terms of suppressing the immune system, to see if this can give us some further guidance, based on our heat shock protein levels.
But the other part to the question I was wondering about is for patients that we know are immunocompromised, not having had COVID, but hopefully won't have COVID, can it be used to guide whether or not they should get another vaccine or whether or not the vaccines are helping them at all?
Yeah, and I think that's kind of the thoughts on some of the hopeful research within the field of COVID. There's so many parts of it that we think puts people at risk. So I think measuring the, the overall, heat shock protein level may be prognostic. So if we can find things to say that, hey, a person that has had these vaccines, their general risk of a systemic very aggressive inflammatory response can be trended by these levels, that might help guide, not just from a vaccination strategy for COVID, but maybe for other, diseases, to say, if these levels are low, it might suggest that they're at an increased risk of, quite a significant response to any kind of viral illness, including influenza.
Thanks, Mike.
Mike, Tomas Godinez had a couple of great questions. I'm going to ask I'll ask them in the order. The first had to do with your evaporating work. And specifically, he was wondering about how you tease out the heart rate lowering effects of evaporating from the heart rate lowering effects of getting better.
So that's an excellent question, and I think that's what's brought us to the next part of the study. So Dr. Godinez has, well, kind of pointed out that, with the typical therapies, people do get better, and maybe the evaporating is just a bystander and it's not really there in terms of improving outcomes. So it is very hard to tease out, and that's what's brought us to kind of the second part of the study. The first part is to say, okay, we know we're not causing harm. The evaporating is not worsening hemodynamics. It's not putting people at risk. And the next part is to answer Dr. Godinez's question, which is, now let's compare it to placebo therapy, which is, standard heart failure therapy, inotropes, diuretics, afterload reductions, and use evaporating alongside to see if there is actually a difference between the two populations. And that the reduction in heart rate and stroke volume isn't just from an improving cardiac state from standard heart failure therapy. So, that's a great question, and that's the hope for the next part of the study, is to investigate that.
So we're running short on time. I'm going to give Dr. Godinez the last question as well, and it has to do with your COVID work. And specifically, you presented data segregated by, for example, heat shock protein levels. What he was wondering is whether you had actually accounted for other potential confounders, such as co-infection, other comorbidities. The ICU patients are heterogeneous, and was that taken into account, or is that a future venture? Yeah,
so great question, Dr. Godinez, as always. So we did account for quite a bit of the same comorbidity. So, hypertension, dyslipidemia, diabetes, coronary artery disease. The risk of reinfection is actually one of our new secondary outcomes we want to look at, because we get to these patients by day 1 to day 3. So we wanted to take a look also, is the heat shock protein levels, their autoantibody levels, do they actually predict as well, the risk of, a confounding bacterial pneumonia? Do they, help in terms of predicting who will get an acute kidney injury? So there's part of it that, so to the question, part of it, yes. So the typical things like typical comorbidities have been accounted for, as well as therapies like dexamethasone, which patients receive tocilizumab. But definitely the last one, in terms of risk of reinfection and complications, is we're going to be looking at the data for that to figure that part out.
So Mike, it is after 9 o'clock, which means that the 50 people that you still have on the call should be doing something else and working. So on their behalf, I'd like to thank you for a great talk. You presented some great work, and it sounds like if we gave you another hour, you could present some more great work, but we'll have to save something for the future. Thanks.
Okay.
Thanks for your talk today.
Thanks.